Hello and welcome to the continuation of our Chapter 9 lecture where we're going to talk about circulatory responses to exercise. And we're going to start off with cardiac output. So first, defining what cardiac output is, it's going to be that amount of blood within our heart that we can pump each minute. And we can calculate this by using heart rate and stroke volume. So our heart rate is the number of beats per minute, and our stroke volume is the amount of blood that we would have in that left ventricle that we are able to eject out and into the aorta with every beat. So we are going to use Q to represent our cardiac output, HR for heart rate, and SV for stroke volume. This you should commit to memory. And it's going to be different for everyone depending on their training status and their sex. Now let's take a look at some of the other components that have to do with heart rate and stroke volume, because clearly if we have these numbers go up, our cardiac output number is going to go up and vice versa. So our heart rate is going to be in tune depending on our autonomic innervation. We know that the sympathetic nervous system will increase heart rate, and if we have more of our parasympathetic nervous system, our rest and digest nervous system, it is going to decrease our heart rate, or not decrease it too much, but keep it at a steady rate. So somewhere usually around 70 beats per minute. And hormones can also influence it, our fitness levels and age. And we're going to take a look at some of these numbers on the next slide. And then we have our stroke volume. So that is going to depend on our heart size. If we have a larger individual, we typically have a larger heart, and smaller, of course, the heart's a little bit smaller. Their fitness levels are affected here as well, and gender. Contractility, meaning how strong is that heart contracting with each beat, and then the duration of that contraction, and then also our preload. So our preload has to do with when our ventricles, let's say, are relaxed. That is going to be, and let me back up, when our ventricles are relaxed and blood is flowing into that ventricle, the volume of blood right before that ventricle contracts, that's called the preload. It's the amount of blood that we are able to keep in that ventricle. And then the afterload is the resistance. So that is going to be the resistance within the vessels before, or let me not say the word before, the resistance that we have within the vessels when we are trying to push that blood from the ventricles into the aorta or the pulmonary trunk. So it's the factor that is going to stop the blood from moving into that direction. That's what we mean by resistance. And then we can calculate stroke volume by taking that end diastolic volume, which is also called preload, and subtracting it from the end systolic volume. So like I said, we'll take a look at some of these numbers here, especially when it comes to fitness level and the sex of the person. So if we are looking at individuals at rest, we could see that an untrained male is going to have a heart rate of 72, untrained female, it has a heart rate of 75. Now, let's take a look at those that are trained. We can see that these numbers have decreased, whereas the stroke volumes for untrained male and female, we have 70 and 60, and then when they're trained, those numbers go up. So notice how, as a result, we're going to have the cardiac outputs be about the same, but they're due to these numbers increasing and decreasing. And then if we look at them while they exercise, we'll see that same shift. So untrained, we're going to see higher numbers. Trained, we'll see lower numbers for heart rate. And then for stroke volume, we have lower numbers. For untrained, we have lower numbers. And trained, we have higher numbers, which now, because there are significant shifts in those numbers with exercise, we'll see that the cardiac output for those that are untrained are much lower than those that are trained. Now, how do we regulate heart rate? We talked a little bit about this when we mentioned the autonomic nervous system component over here. And so what are the actual nerves that go and supply this? So when we look at our parasympathetic nervous system, the rest and digestive system, we are going to utilize a nerve known as the vagus nerve. So the vagus nerve is a cranial nerve, and that nerve is going to come off of the medulla. If we look at the brainstem, and you could see it in the blue over here, and it's reaching over, and you could see that it ends here in the heart at the SA node and the AV node. And that is going to slow the heart rate by inhibiting the SA node, which we know is our pacemaker, and the AV node, which is where the SA node sends its neural signals to then send it down to the AV bundle, down the right and left bundles, and the Purkinje fibers in order to get the ventricles to contract as well. Now let's take a look at our sympathetic nervous system. Our sympathetic nervous system is going to innervate the heart through cardiac accelerator nerves. And so you could see some slices of the spinal cord here, which is where these nerves are going to come from. And here where we have the ventral horn, where all of our motor nerves are, we have a cardiac accelerator nerve extending out and headed over to these various points in the heart of the conduction system. So note how we have a branch going to all the different components of that conduction system. And by stimulating or sending impulses through these nerves, we are going to increase heart rate, and specifically doing that at the SA node and the AV node. Now, low resting heart rate is due to a parasympathetic tone. You sitting here listening to this lecture is going to stimulate your parasympathetic tone, unless you're somehow feeling really anxious about what we're thinking about, and then probably your sympathetic nervous system is there a little bit. Or if you're on a treadmill listening to this, right, then sympathetic would come into play. And then we see here that our increases in heart rate begin at the onset of exercise due to the parasympathetic nervous system withdrawing at this time. And that is going to be up to approximately 100 beats per minute. And so we see at the beginning here, we have that sympathetic withdrawal. So we're not studying and keeping that heart rate low because the parasympathetic nervous system is gone. And then we start to see that the sympathetic nervous system is going to become increased as the exercise intensity increases. And so we could see we have higher heartbeats per minute at that time. Next, let's take a look at a clinical application regarding heart rate. You may have heard of people taking something called beta blockers, and these beta blockers is just a easier name to represent our beta androgenic blocking drugs. What these drugs do is they compete with epinephrine and norepinephrine for beta androgenic receptors in the heart. Now, why do we care about those receptors? These receptors are there to receive epinephrine and norepinephrine when our sympathetic nervous system is stimulated. So we are going to have this representing our heart at normal, let's say sympathetic stimulation, right? We have epinephrine, specifically norepinephrine, released by our sympathetic nervous system. And that, as we said in the previous slide, is going to increase our heart rate. It's going to help to increase our cardiac contractility and increase our cardiac energy demands. And you could see here the ECG is showing normal. We got our P wave, QRS complex, and the T wave, right? So with these drugs, they compete for those receptors, and they are blocking those receptors. So when they are blocked, we no longer have a place for, let's say, norepinephrine to attach and increase heart rate. So as a result, that is going to decrease our heart rate and contractility, and in turn, it lowers the myocardial oxygen demand, because if we are increasing all of these things, we are going to reduce what the heart needs, right? It's not working as hard. And so I know we still have some up arrows here. We're still going to have a little bit of increase, but it's not as much of an increase as we see here with norepinephrine attaching. So these are typically prescribed for patients with coronary artery disease and hypertension. And like we said, will lower that heart rate. So especially during submaximal and maximal exercise. So this could be really important for exercise prescription. Our next topic is on the heart rate variability, and this is going to be that time between our heartbeats. So if you look at this QRS complex here and here, remember that that is representing when our ventricles are depolarizing, meaning they're contracting, and the atria are repolarizing, so they are relaxing. And so that is representing our heartbeats. And so the heart rate variability is then measured or calculated as a standard deviation of the RR interval that we showed over here. And this is a balance between our sympathetic and parasympathetic nervous systems, which we call the sympathovagal balance. And this is the neurocardiac function that is generated by the heart-brain interactions and the dynamic nonlinear autonomic nervous system processes. So when we have a wide variation in this heart rate variability, that's considered healthy. Kind of think about our heart is not having to work so hard in order to do its job. So a low heart rate variability is a predictor of cardiovascular morbidity and mortality. And so we see that in patients with existing cardiovascular disease, because as these get closer together, we are going to see that the heart is working harder to push that blood out and get it to the rest of the body. Now let's take a look at regulation of stroke volume. We talked a little bit about end diastolic volume, which we also call preload. Remember, that is when we are taking the amount of blood within the ventricles at the end of diastole. Remember, diastole is when the ventricles are relaxed and we are shifting that blood from the atria into the ventricles. So that volume is at the very end when we've got all of that blood in the ventricles. And our average aortic blood pressure is going to be that pressure that the heart has to pump against in order to eject the blood. And that is also called our afterload and is represented by our mean arterial pressure. So let me go back to a more anatomical representation of the heart really quick. Let's use this one here. So we have all of this volume of blood in the heart after diastole. That's our preload. And now we have to push against the pressure that is closing the aortic semilunar valve and the pulmonary semilunar valve in order to get this blood out of the ventricles. So the resistance that we have within our pulmonary trunk and the pulmonary arteries and the aorta here is preventing that blood from moving through. So the afterload, again, is that aortic blood pressure, okay? So we also want to think about the strength of our ventricular contraction, which we term contractility. And it's enhanced by circulating epinephrine and norepinephrine. Remember, that's going to be released by our sympathetic nervous system, right? That is going to allow that contractility to increase and allow a greater strength of contraction to that ventricle to get the blood to go to the aorta and the pulmonary trunk. So let's take a look at that end diastolic volume a little bit closer. As that blood fills into the ventricle, we have this greater stretch of our ventricles. And so the more that we are going to stretch, the greater or more force the ventricle is going to want to have to push that blood out of the ventricle. So that is known as our Frank-Starling mechanism. We get a great stretch of the ventricles, meaning we're going to get a greater contraction of the ventricle to push it out. And so we know that this is also dependent on, or the end diastolic volume, our preload, is also dependent on our venous return. And so that venous return has to do with venoconstriction. How much are our veins constricting? And this deals with our sympathetic nervous system once again. And how are we able to get that blood back to the heart? We're going to use our skeletal muscles along the sides of our veins to push that blood. So we have rhythmic skeletal muscle contractions and also these one-way valves in the veins to make sure that blood is continuing in that one direction to the heart. And then within our thorax, we're going to have something called a respiratory pump by changing the pressures in the thorax to help pull that blood toward the heart as well. Just as you're breathing and using your respiratory muscles, that helps to push against the veins, bringing it back to the heart. Now let's look at this graph over here. We could see that our normal resting volume is for end diastolic volume is going to be somewhere around 140 milliliters. And that makes our stroke volume close to like 80 milliliters. And so when we are having increased venous return, let's say we're using all of these components, we will see that that will increase our end diastolic volume because we're bringing more blood into those ventricles now, which in turn is going to increase our stroke volume as well. And here is a graph showing the effects of sympathetic stimulation on stroke volume as well. You could see here with our end diastolic volume at, let's say, 130 at rest is going to give us about, I would say, 55 or 60 milliliters for our stroke volume. And when we have our sympathetic nervous system increase contractility, we will see that the end diastolic volume will be the same here, but it is going to have a greater stroke volume. And here's just a little figure depicting what we talked about with cardiac output being calculated by our heart rate or cardiac rate and stroke volume, and our parasympathetic nervous system really affecting our heart rate, but sympathetic nervous system affecting both stroke volume and our cardiac rate. And the components here with our stroke volume dealing with mean arterial pressure, really the resistance within those the aorta and pulmonary valve, or pulmonary trunk, I should say, and the end diastolic volume, the amount of blood that we have in the ventricles, and how much is our ventricle contracting to push that out. And it has to do with that Frank-Starling law in which we have more volume. It means we're going to have greater contractility. And let's talk about some of the physical characteristics of blood. We are talking about moving this blood within our cardiovascular system. What's in it? So if we were to take a test tube and put some blood in it, we are going to then put it into a centrifuge. So what that centrifuge does is it spins around and around and around, and we start to see a separation of the components. The heavier components are going to go to the bottom of the test tube, and that is going to be our red blood cells. So we really call, I know it says cells here, I think that's how your book refers to it, but the true name for these components are called formed elements. And so our red blood cells, or our erythrocytes, are found at the bottom here, and they're going to make up about 45% of our blood. And their job is to have those hemoglobin molecules in there to carry oxygen. Then in this area, which we call the buffy coat, we are going to have our white blood cells and our platelets. Our white blood cells really work within our immune system to defend our body against infections, and our platelets are going to play a role in blood clotting. So we have this buffy coat, the white blood cells and platelets, making up less than 1% of our blood, which is kind of amazing knowing what they do for us. And then just to go back, the term hematocrit represents the percentage of blood composed cells, and that's going to be 42%. And lastly, we have plasma. Plasma makes up about 55% of our blood and is more of the liquid portion. You could see that it has this golden hue to it, and we're going to have a ton of things we find within the plasma, such as ions, hormones, proteins, other biomarkers, and sometimes antibodies circulating. Next, let's talk about the relationships among pressure, resistance, and flow. First, focusing on blood flow, that is going to be proportional to the pressure difference between the two ends of the system. And what we mean by two ends of the system is looking at the blood flow as we're leaving the left ventricle, in which we can see our mean arterial pressure is approximately 100 millimeters mercury, circulating through our body, giving off that oxygenated blood to our tissues, and then taking our waste and carbon dioxide through the veins and back to the right atrium of the heart. And notice how as those veins, the vena cava, are bringing that blood back to the heart, the pressure changes to 0 millimeters mercury. So as we move through this system, the pressure is basically dissipating. And this blood flow is then going to be inversely proportional to resistance. You know that we've talked about resistance a little bit before in talking about things occluding arteries and slowing down that flow, or the vessels constricting, making that lumen a lot more narrow. That creates more resistance. So here's our formula for blood flow. It is that change in pressure. So when we talk about the change in pressure, it's that difference between the mean arterial pressure and the right atrial pressure that we see over here. So it's going to be 100, right? Over resistance. So what is resistance dependent on? It's going to be dependent on the length of the vessel. The second thing that resistance depends on is the viscosity of blood. And this is really pertaining to the thickness of blood. We talked about in class how when we have more red blood cells, that is going to make the blood thicker and more viscous. So you can think that maple syrup is more viscous than water. And then we have our radius of the vessel, which is going to give our greatest influence to resistance. If you look at this graph or figure on the right-hand side here, you could see that we have our larger vessels here at the arteries and our large veins. And we know that leaving at the left ventricle, we are going to have the greatest amount of pressure, and that's on our y-axis here. So our large arteries have a ton of pressure that builds up, and as we narrow that diameter, moving to our arterioles and our precapillary sphincters and our capillaries, we're going to start to see that the pressure decreases. And that too is also because we're going to have more resistance, especially once we get down to the capillaries, and that blood has to go through many smaller vessels to then travel through our venules and our veins back to the heart. Now, yes, the large veins are going to have a larger radius, but at this point that pressure has dissipated and we have nothing to increase that pressure, so it just stays low. And then other sources of vascular resistance would be our MAP, the mean arterial pressure, decreases through the systemic circulation, as we said. The largest blood pressure drop occurs across the arterioles, and you can see how steep if you were to draw a line through all of this here, how steep that would be. And that's because our arterioles are known as resistance vessels. They are going to be the ones to be able to vasoconstrict and vasodilate. That will change blood flow and in turn the blood pressure. Now we know that when we exercise, the demand for oxygen within our muscles is going to increase. And that increase is about 15 times to 25 times greater than at rest. And so how can we deliver this oxygen to our muscles? We do that by increasing our cardiac output, having a redistribution of blood flow, meaning that we are going to not pull blood away from, but not have as much blood flow going to our inactive organs and instead shift it to our working skeletal muscles and our working cardiac muscle cells to be able to deliver the oxygen where it's needed. So how can we increase cardiac output? It is going to increase just by our heart rate increasing as we're exercising. And this is linear to our max heart rate. So we can see that linearly changing as our heart rate increases up to our max heart rate. Now we can easily calculate this using this formula here. For adults, max heart rate is going to be 220 minus whatever the age is in years. And for children, it's the max heart rate is 208 minus 0.7 multiplied by their age in years. And then we also have to have that increase in stroke volume, because if we remember that formula, cardiac output equals heart rate times stroke volume. So that stroke volume increases, and then it's going to plateau at about 40 to 60% VO2 max. But we don't see that same plateau in highly trained subjects. Now, why does that happen? Because at high heart rates, the filling time is going to be decreased, and we also see a decrease in that end diastolic volume, which in turn is going to decrease the stroke volume. This is for our untrained subjects. The stroke volume does not plateau in the trained subjects, as we said, and that's because they have an improvement in their ventricular filling, which means we're getting a greater volume of blood filling up the ventricles, and in turn we're able to pump more blood out of those ventricles at a higher heart rate, and that of course is going to increase our cardiac output. Next, let's talk about the impact of body position on stroke volume during exercise. It seems to have a major influence on stroke volume. And so it's true at rest and during exercise. It's related to the effect of gravity on our venous system. So gravity is always pushing us down, right? And so gravity will promote the pooling of our blood in our legs, which lowers the venous return and lowers the end diastolic volume. And this is also due to the F-Starling effect, meaning that when we have that low end diastolic volume filling up the ventricles, we are not going to efficiently be sending out blood to our circulatory system, and hence we're not going to get our venous return back as well. So upright exercise results in increased stroke volume due to that end diastolic volume being larger and increasing the venous return. And we also see then an increase in the stroke volume at these high heart rates while we're exercising. When we have a supine type of exercise, meaning you're laying on your back, belly up, for example, during swimming, we are going to see that there are small increases in the stroke volume. And this is due to resting stroke volumes being relatively high while we are in the supine position. This slide here is actually something that we already mentioned in this lecture, that our skeletal muscles that are active, that are working, are going to have increased blood flow to them. At rest, we have about 15 to 20% of cardiac output going to the muscle, and that is going to increase up to 80 to 85% during maximal exercise. And of course, we're going to decrease our blood flow to inactive organs, such as the liver, kidneys, and our digestive tract organs, such as our intestines, the stomach, and the colon. And so we have redistribution that depends on our metabolic rate, so we really have to consider our exercise intensity. And the way our body is going to decide what organs get more blood flow and in turn more oxygen is through auto-regulation. When we're able to have our blood vessels vasodilate to allow more blood flow to go to that skeletal muscle tissue that has higher metabolic demands, we are going to be able to deliver that oxygen. And this is due to changes in oxygen tension, our carbon dioxide tension, nitric oxide, potassium, adenosine, and pH. You could see in this figure over here, when we are at rest, the muscle blood flow is low, but as we increase our intensity, we are going to increase muscle blood flow. And then our vasoconstriction will take place for our visceral organs, mostly meaning our digestive organs that are inactive. And so that sympathetic nervous system is responsible for the vasoconstriction. And within the sympathetic nervous system, we have this splanchnic blood flow. So you could see that when we are at rest and our oxygen consumption is low, we are at a pretty high level of this splanchnic blood flow, and then we start to see it decrease as we exercise. And just as a reminder, our sympathetic nervous system is causing vasoconstriction because that is going to decrease blood flow. Now, one of the ways that we can get vasodilation to our skeletal muscles, increasing blood flow, is by having our vasoactive regulators. That is going to include nitric oxide, prostaglandins, ATP, adenosine, endothelial-derived hyperpolarizing factor, and more things. We can see these factors are produced in the endothelium or our arterioles. When we say endothelium, I want you to think of that tissue that lines the inside of our blood vessels. It's just a fancy word meaning simple squamous epithelium, and it helps to promote smooth muscle relaxation so that we can go from a more narrow lumen to a wider lumen when we do vasodilation. And so when we vasodilate, we get more blood flow. Now we know that as we exercise, we are going to have changes in our heart rate and blood pressure, and that really depends on the type of exercise, intensity, and the duration of the exercise. We'll even see differences in arm exercises versus leg exercises and the environmental conditions in which this takes place in. For instance, if we are in a hot or humid type of environment, we'll see that there is even more vasodilation taking place versus in a cool environment. And our cardiac pressure and ventricular volumes are going to change dramatically during exercise. Our stroke volume is elevated because of that increased end diastolic volume or preload, and we see a decrease in systolic volume. That end systolic volume is referring to the volume of blood in the left or right ventricle at the end of the systolic ejection phase, immediately before we begin dystole, or when we start filling up the ventricles. If we look at these two graphs too, we can see that here is what our heart is doing when we are at rest, and this is our heart when we are exercising. And notice how we have time reductions in the cardiac cycle. If we look at the cardiac cycle over here at rest, we see that it takes about 0.8 seconds, whereas when we're exercising, it takes about 0.3 seconds. And that is because our intraventricular contractions are taking place a lot faster, and that intraventricular pressures are also increased due to us having a elevated afterload during exercise, meaning we are experiencing more resistance in our vessels that the end diastolic volume has to overcome in order to have the ventricles contract and push that blood to the rest of our body. You might be wondering, how does emotional influence affect the heart? We see that there's elevated heart rate and blood pressure in an emotionally charged environment, and this is due to increases within our sympathetic nervous system. It's kind of how your nerves and your anxiety become a little bit heightened right before a competition. And it can increase in pre-exercise heart rate and blood pressure, but it does not increase peak heart rate or blood pressure during exercise. Next, let's talk about the transition from rest to exercising and into exercise recovery. When we first start exercising, we can see that all three components here, our cardiac output, stroke volume, and heart rate, all start to rapidly increase. And then it will plateau in submaximal, meaning below lactate threshold exercise. As we start to recover, we see that there's a decrease in all three of these components, but it does really depend on the duration and intensity of your exercise and the training state of the subject as far as how these numbers fluctuate. Now, we've talked about incremental exercise before. Regarding our heart rate and cardiac output, we'll see that it will increase linearly when we increase our work rate, but we reach that plateau at 100% VO2 max. Our blood pressure is going to increase linearly as well. We'll see that systolic blood pressure specifically will increase, whereas the diastolic blood pressure remains fairly constant. Another increase we see is the double product, which is referring to how hard is the heart working. And that increase takes place linearly as we are increasing our exercise intensity. And we can see that illustrated in this table here. Here is our heart rate at rest, our systolic blood pressure at rest, and the double product. And note how as we are increasing intensity, so in turn we're increasing our oxygen consumption, that our heart rate is increasing, our systolic blood pressure is increasing, and in turn, the double product is increasing. Speaking of increasing intensity, we also see that with a difference within arm versus leg exercises. And it seems that almost when we do our arm exercise, our body is experiencing more intensity because we see that there is an increase in heart rate and blood pressure when it comes to arm exercises versus the leg exercises. And when we look at the heart rate down here, it is going to be due to a higher sympathetic stimulation, whereas our blood pressure is due to vasoconstriction of large and active muscle mass. So remember that vasoconstriction is going to increase the pressure within that vessel. And within both of these figures, we can see that the arm exercise line is always higher than the leg exercise. Now, what about intermittent exercise? Recovery of our heart rate and blood pressure will take place between the bouts, depending on the person's fitness level, temperature and humidity, and the duration and intensity of the exercise. And we could see that taking place over here. As person is cycling, we're seeing that is going to be where we have the watts higher over here. We have our heart rate increasing as we are doing the work, but then during the periods of rest, we see the heart rate decrease. But as that exercise continues and the duration increases, we see that the rest periods are resulting in lower amounts of heart rate, meaning that heart rate is going to increase as the exercise continues. And when we have heavy intensity intermittent exercise, we are near maximal heart rate values. Now, if we shift gears and look at prolonged exercise, we can see with cardiac output, it is going to be maintained and remain consistent. Whereas with our stroke volume, we will see that gradual decrease. And this is due to dehydration as we're sweating and a reduced plasma volume. And with heart rate, we will see a gradual increase during this prolonged exercise and specifically within heat. And this is known as our cardiovascular drift. I really like this figure here because it really gives a nice summary as to all of the cardiovascular responses to exercise. This pieces together all of the things that we've discussed within this chapter. And our last clinical application is on sudden cardiac death during exercise. This is uncommon. It happens in about 1 in 200,000 youth athletes, and it's caused by abnormal lethal heart rhythms. In children and adolescents, it could be due to genetic anomalies of coronary arteries, maybe not giving proper blood supply to certain areas of the heart, or cardiomyopathy, where you can see that pictured over here on the top right, where we will have a thinner ventricular wall and there's more space for blood to fill. And then we have myocarditis, which is going to be inflammation of the actual muscle tissue. And in adults, it could be due to coronary artery disease, in which we have those fatty plaques narrowing the coronary artery walls, or cardiomyopathy as well. And a medical exam can identify those that are at risk. The last thing we're going to talk about is the central command theory, and essentially how are we regulating the cardiovascular adjustments when it comes to exercise. And we have this initial drive that comes from our higher brain centers that will get our cardiovascular system to adapt to the exercise that we're performing. And this is centrally generated by motor signals. And we can fine-tune this feedback from our heart mechanoreceptors, which are sensing for that change, right? That stretch that we're having within the heart as it's filling up with blood. And then we have our muscle chemoreceptors that we really talked about when we discussed muscle fatigue. And they are going to be sensitive to our muscle metabolites, such as potassium and lactic acid, and in turn the pH. And we have something called the exercise pressor reflex, which is a reflex that is going to increase the sympathetic activity to our heart and also the systemic vessels, so that we can decrease that parasympathetic activity, the rest and digest, right? We don't need to steady our heart rate, we need to increase it. So we're also going to increase the blood pressure and our total peripheral resistance through vasoconstriction by the sympathetic nervous system being turned on or activated even more. Then we have our muscle mechanoreceptors, which are going to be sensitive to the force and the speed of muscular movement. And lastly, our baroreceptors that are sensitive to the changes in the arterial blood pressure. And here is our summary of all that we have discussed. As usual, if you have any questions, feel free to reach out.